Good morning, everyone. My name is Eberhard Grube. I'm coming from Germany. I'm here with very good friends, Dr. Bapat, Dr. Owen, Christopher Raffel, and John Webb from Canada. Welcome to this wrap-up interview at TCTAP 2018. We have 30 minutes to discuss a little bit the issues of TAVR trials and some other topics that are pertinent and important. So while we go through the slides, we have issues that we will be discussing, the guidelines and the low-risk trials that are underway, and of course new indications. And while we're discussing this, maybe we can start with the 2017 focused guideline update. And maybe John, would you mind commenting on the slide that you can see here?
Well, you know, in the early days, we made the mistake of comparing ourselves against patients that couldn't have surgery, and Partner 1 and subsequently CoreValve showed that this is now the default therapy for patients who can't have surgery. And then we compared patients at high risk, and in my mind, those trials basically showed that TAVR was at least as good, or possibly the transfemoral procedure was better than high-risk surgery. We moved on to intermediate risk. We now have a mortality rate of around 1% in patients at intermediate surgical risk, which would be a risk of mortality of 4 to 8%. So a mortality less than or about a quarter the lowest intermediate risk patients having surgery. And yet we're still aiming towards proving superiority or equivalency in low risk patients, although many people would argue we're already there.
Yeah. Would you both of you, Chris, would you predict what the outcome of these trials will be, the low risk trials?
Well, I think certainly based on the high and intermediate risk trials, I think the low risk trials are clearly going to show at least equivalence. And what we're seeing now in clinical practice is expectations from both patients and physicians, and referring cardiologists are pushing towards the intermediate and low risk patients.
Yeah. Vinny, what people are many times confusing is low risk and young age. Would you mind pointing out the differences, that we should not confuse that?
I think absolutely. It's the most relevant point. I think that most of the TAVR trials, the average age has been 80 plus, and even in the low risk trial is going to, if at all, be at least 75 plus. These are the patients who are healthy, they've got good quality, they want to improve their quality of life. I think younger patients with more bicuspid disease, or patients in bicuspid disease who may need coronary intervention later, the low-risk trials are not probably going to address those particular patients. Yeah. But what's definitely one thing in the low-risk trial is also they're going to challenge the durability data for both surgical valves as well as TAVR with the systematic CT scan studies for not just 1 year but 10 years. And I think this field is probably going to evolve hand in hand with that evidence. I think it's a very important step for both therapies.
Yeah. John, do you think that our complication definition should be revisited when we go into younger age groups, not necessarily lower risk groups?
You mean the complications in terms of the definition of stroke and vascular injury?
For example,
yeah, you
PVL and durability issues.
You know, I think really the issues these days have more to do with late outcomes in lower risk patients, because often these patients do have longevity in front of them. So we should be looking at durability, but we're not really going to have that data for many years. That being said, we have a lot of data already, better than a lot of surgical valves. We have patients in my center, for instance, out to 11 years still alive. We have good in vitro studies. We have 5-year durability with both CoreValve and the SAPIEN type valves that's equivalent to surgery. So yeah. You know, we're kind of there.
So going through the slides, Partner 2, I mean, would you mind making some comments on Partner 2? And this is SURTAVI, wrapping up for our listeners.
Well, I'll
and
just
viewers.
comment on Partner 2. If you noticed, it looked like the outcome was a little better in terms of mortality with Partner 2 as opposed to surgery. But I remember that the SAPIEN valves have always been, if you don't mind, handicapped by having transapical and alternative access patients mixed in with those. And if you actually separate out the transfemoral patients, the difference was quite dramatic in terms of lower mortality and lower stroke rate, even with the old SAPIEN XT platform.
A word about SURTAVI?
Well, SURTAVI was a slightly lower risk trial. It showed superb outcomes, I think, with the core valve. It didn't have the quotes handicap of having transapical type patients in there, but really excellent outcomes with both trials.
Yeah. Chris, could you summarize the low-risk trials that are underway? And do you really think we need many of those? Are they important? Or once the 3 big ones are out, do we need the other ones?
Well, obviously the ongoing trials are Partner 3, which I think is finished recruiting now, and the Eberhard trial in a low-risk STS less than 4%. Clearly, I think if you're treating these low-risk patients and the surgeons do it very well, and our surgeons do it at a mortality of almost less than 1%, we have to prove that we can do that. So I think we certainly need the randomized trials.
Yeah.
I think the next comment is we also do need to be careful that there are lots of valves that are going to be coming out in the horizon, and all valves may not be equal. So that is something else. I mean, we have previously criticized the surgeons for saying, oh, you bring out a new valve and you assume it's the same as the old valve. And percutaneous valves, that's something else we just need to be careful of and maintain the data for the valves that have been studied.
So an interesting question comes up when we see, all these lists of these low-risk trials. Do we have to really repeat all those with the new devices that are maybe not on the market yet or are supposed to be coming? Are they jumping in? Just as an example, the Symetis valve, do they have to repeat all of this, or do they just join the group saying we just go directly to the low risk? What do you think, Vinny?
Well, I think this is an important question, and whether you compare with a commercial valve which already has proven some benchmark, and I think randomized trials are probably slowly unnecessary. You could do a large registry in similar patients and do propensity matching against a benchmark, and I think the benchmark is already there in terms of Evolutar or Sapien 3 platform. And I think we need to pause somewhere, because reintroducing different models every 2 years is probably also going to hurt the field, because we want to understand which valves do very well, and all design features may not be the best. One of my major concerns is pacemaker rates, and I think we have not addressed that, whether in low risk with patients with longer life expectancy is going to affect their life expectancy and results.
Yeah, that was basically what I was aiming at when I asked John that question. Do we have to revisit complications? The pacemaker rate, you might argue, in an 80-year-old, it's not such a big deal, but when you go into younger age, it is going to be maybe an issue. And apart from cost, geographically, it might be, an interesting question. Do you believe, and I would be interested in any of the 3 of you making that comment, do you really believe that we can get down into the 1-digit surgical-like number with pacemakers, or do we have to accept a low double-digit number with TAVRs?
Means we know that the self-expanding devices, by the nature of the design itself, are going to have probably double-digit number. The only way we can reduce it is high implantation, but there's going to be a limit of how high we can implant.
Right.
So I think unless we come with a reliable high implant which is secure, which we have seen with some platforms, maybe Symetis can address that in some ways, but some other platforms we have seen the really high. So I think there's always going to be limitation. The balloon expandable valves are, I think, coming as near as surgical valves now in terms of pacemaker rates.
Yeah, I'm not so sure the issue is balloon expandable versus self-expandable. You can have self-expandable valves that have very low pacemaker rates as well. And it largely has to do with positioning, but also sizing and the pressure on the AV node. We may have new valves that actually sort of have some kind of defect in the region of the AV node where there's less likely to be pressure put on that area. I find it hard to believe that we're going to get down to 1% rates, though certainly with the kind of valves we're implanting today, there'd have to be dramatic changes.
I would agree. Personally, I would agree to that. What do you think, Chris?
Yeah, I think I would agree with that too. Yes.
Yeah. Well, maybe we have to live with that, and we'll have to see. To me, we know factors that increase pacemaker rates, but to me it is not quite clear, at least not until today, if it is a number of factors that's contributing it, or is it just 1 or 2 main things. Anyway, we have to move on, leaving the low-risk trials, and we come to the interesting question of asymptomatic or new trials that are opening up new indications. And while we're looking at the slide, the early TAVR trial, and here the TAVR Unload trial, would anyone comment on the early TAVR trial? Chris, maybe you can start.
Well, I suppose the first question is who we consider as asymptomatic, and that's always been a difficult question. I think we probably have underestimated the symptomatic status of patients and not truly addressed patients and monitored patients who are really symptomatic. So the first thing I think is your definition of what is an asymptomatic patient. The next question is, are we going to have enough event rates to prove a difference? And that's what I'm not sure about.
Yeah.
Because I don't know we have those endpoints as yet to know how much that's going to take.
John, any word on the?
I think that we all see these sorts of patients, don't we, where people have very high gradients and they maintain their asymptomatic, but if they're really limiting their lifestyle, they're limiting their activities. This trial does have an exercise test built into it, and really most people don't put these patients on treadmills in the first place. It'll be interesting to see how easy it is to enroll patients. I'm sure there's a role for early TAVR. I think it's a bit premature for us to be worrying about this. We still have to go to the low-risk patients, and still this procedure is not yet mature.
I think one of the problems we have faced in enrolling is a lot of these patients who are typically asymptomatic, they are more worried when we discuss about, as you know, that FDA has mandated that we have to discuss durability issue with these patients proactively. And this is the point where, the stroke rate and durability kind of puts them off. Having said that, I think we have found that stress test is quite important, and a lot of these so-called asymptomatic patients become symptomatic on stress test and then go on to have a TAVR happily. And those who are not, I think the main test is how many are going to migrate from medical therapy or observation to this, and that's probably going to prove, give us some more insight about aortic stenosis progression.
I mean, we can see, and I think there's a lot of reasoning for it before the damage in the left ventricle is done. By waiting too long, when do you start intervening? It's the same basically for the mitral valve situation. And a trial like that is very important. Whether we call it asymptomatic, I have a problem with asymptomatic patients. I mean, the best, and that's part of the trial here, is the stress test, whether that really is an indication for asymptomatic. But stepping in earlier than traditionally with symptoms, I think it makes a lot of sense, and we'll see how that goes and how the enrollment is. I understand the enrollment is not that easy.
Yes, it is, I think.
And the other issue, I think, is surgery has still been the gold standard, at least for these patients.
Right.
And we haven't proven, and I'm sure we will, that the low-risk patients do just as well with TAVR. But now we're going beyond that to asymptomatic patients, and we're sort of leaving the surgeons out of it, which arguably is a little bit concerning.
Yeah. John, TAVR Unload, intermediate aortic stenosis with congestive heart failure, basically the same direction.
This is a fascinating question. If you have poor left ventricular function, surely even moderate aortic stenosis must be a handicap, just as systemic hypertension is a handicap, and just as we put people on afterload reducing therapy. So there's a lot of sense in this, I think. The question is going to be, one of the questions is this the time to do this procedure, this study? Are we good enough at this point? And maybe the answer is yes. I think it'll just be a fascinating trial to see how this ends up.
Yeah, I mean, any word on it, Vinny?
Yeah, I think again, enrolling these patients, because we always felt that there are a lot of patients of this kind, but once the trial's running and started, it's hard to find these patients which are for unload or for early TAVR. And I think this is the problem we are facing at present, is enrollment. But this is a very interesting question, which I think will be positively answered by these trials.
Yeah. Okay, we have to move on, and we come to the second part, embolic protection during TAVR. Anyone would like to comment on that? Chris, nobody's volunteering, so...
we don't have Dr. Sievert and Dr. Sievert to comment on it. Clearly, I think the jury is still out on should we use it or shouldn't we use it. We certainly don't routinely in our part of the world because of the added cost involved as well. But a good point that was made was that when we're moving towards these low risk patients, should this be something we're adopting? A disabling stroke is bad for anyone.
Before I come to John, I know your opinion already, so why don't we just go to Vinny first?
So, having moved recently to America, I think I've seen the market forces acting, and especially in Sentinel. And our patients expect us to use Sentinel. It's not reimbursed, but it's one of the procedures which is kind of become default now. We struggled a lot with this to start. We were trying to select few anatomies where we should be using it, so very calcified valves, etc. But we don't see strokes differentiating between these patients. So now we have given up. And if anatomy is suitable, that means if on CT we think it is favorable, and the fact that we can pass the wire, we use Sentinel in every patient.
Yeah, well, other centers do the same, as we all know. Out in Los Angeles. But anyway, John, of course, now...
Well, we may be on a gradient here in terms of pro versus not so much pro. I mean, there's no denial that you get these embolic material back with Sentinel and these other devices. I think it looks from the studies as though some valves more than others, this is an issue, and some may benefit less. We get better and better with this procedure. We get less and less traumatic. We're not pre-dilating. We're not post-dilating for most part. In my setting, we figure that for us to use these devices routinely, we would spend something like $500,000 to prevent one major stroke. And in terms of cost benefit, it just doesn't make any sense for us, particularly when we would do less TAVR in exchange. We don't have endless funding. So I can't see us using this routinely until we have more solid proof that we do than we do with the current generation devices. And I would also argue that younger patients who might have the most benefit and have to live with the stroke the longest probably are also going to have the lowest risk of stroke.
Exactly.
And so the benefit will be very little, and cost benefit will be disappointing.
Yeah, very reasonable. I mean, as you all know, that Sentinel or Claret is in discussion with CMS. Do you think that apart from the arguing that you brought forward, that the cost is an issue? In other words, if CMS would reimburse,
yes,
would you think this would be more, going into routine use?
Oh, there's no doubt about that. I think most centers in New York are already forced to use it. They take a loss in terms of the cost because we have seen a patient drift to centers where it is used. In fact, I think we are assuming that in younger patients the stroke will be less. Probably not, because if the stroke is coming from the aortic valve interaction, as we have seen that some devices have it more than the others. So I think this is where I feel that this is going to become a routine expected practice in patients. Like we expect now everybody to have ProGlide for vascular closure and not cut down. I think similarly there's definitely a trend, and I think that trend is going to be there with or without evidence.
Yeah, it's going to be interesting what's going to happen. And I think if we follow the FDA panel, basically there has been a discussion about endpoints, composite endpoints, imaging endpoints, all of these statistics. At the end of the day, what weighed very heavily when each of the panel members was asked, if you have that procedure, would you like the protection or not? That brings something into the game that it is very, very difficult to answer by statistics only. I mean, I can see the argument. Yesterday, Horst brought this forward. We'll see what the future will bring. Personally, I think once reimbursement is settled, then America will be moving forward, and that's probably an indication for the rest of the world. So now we have to, my favorite, I have to admit, TAVR. is the anticoagulation following TAVR, with the advent of the thickening, whether you call it thickening with leaflet motion or without, or whether you call it some imaging artifacts. Anybody able to talk about the ARTE trial and the antithrombotic for TAVRs? John?
Well, we have a number of trials that have looked at single versus dual antiplatelet therapy. This is just the most recent and arguably maybe the best one, but it's still a small trial. And we don't have convincing evidence that single is better or worse than double antiplatelet, but the weight of evidence, I think, is actually in favor of single antiplatelet therapy, in favor of aspirin alone. And at my center, we have actually taken this jump, and single antiplatelet therapy is our routine. I think the bigger question really is, do we need more aggressive anticoagulation other than clopidogrel or some drug like that? Should patients be on NOACs or warfarin for some period of time? And that's unknown.
Yeah. Chris, would you comment on the ongoing trials, antithrombotic trials?
Well, this is what John was saying. As far as antiplatelet therapy is concerned, I think, most people are happy with what they're doing for their individual center, and I think we as well are going more towards single antiplatelet therapy. The question is, again, based on the CT trials we've seen, whether anticoagulation is with a sort of antithrombin, a NOAC or a DOAC as they called, is beneficial. Certainly in our center, we have not been concerned about this and have not really had many issues with late thrombosis of the valves. And certainly in the high-risk group patients, adding a second anticoagulant comes with its bleeding risk. I suppose it's a question that needs to be asked, but certainly from our clinical perspective, it's not something that we have been too concerned about, clinically anyway.
Do you share this, Vinny?
I think this is very interesting because definitely single antiplatelet is important. No antiplatelet is bad. It's the question of anticoagulation and how safe it is and how long we should give. I think that is the main question we need to ask now. We know for sure that if we study, like in these trials, every device has nuances, every anatomy has nuances, so we are going to definitely see some incidence of leaflet thickening, thrombosis. These antiplatelets are going to make a major impact, as we have seen some early indications from low-risk trial from MedStar Washington.
Exactly. I mean, the Lotus trial is a good example on that, yeah, with and without. But do you think that we are digging deeper into this problem? Do you think this is just an imaging problem, or do you think it's a real problem?
I really don't think so. We're the core lab for both the Medtronic and Edwards CT thrombosis evaluations, and we're very cognizant of this. And I have to say, we think we see quite a lot of leaflet thrombosis. If you start looking for an increase in gradients between post-implant and 1 month, you'll not frequently find the gradient increases, and if you start looking, thrombosis is involved. I'm not sure of the clinical significance, but I think it's pretty common. And one of the areas that we're particularly concerned about is valve and valve implants. I think the risk of thrombosis is much higher. And we actually have gone over to routine anticoagulation of valve and valve implants for a period of 3 months with very little evidence to back us up, except we're seeing too much thrombus in that setting.
It's this brings up the same question, where's the clinical evidence? Nothing is happening, which is not quite true, by the way. If you have thickening, some things happen. It's not like it's just an imaging phenomenon, yeah. And we will see what's going to happen. There are reported stroke with thickening, and it's quite natural. If there's thrombosis, chances are there that something is flying off and it's hurting you.
I think one of the bigger concerns is durability.
Right.
If you have subclinical thickening of a valve, that has to have some relationship, I would think, to late durability.
Absolutely. Yeah.
And I think the other issue is it's almost a corollary to stent thrombosis, whereas you have all these risk factors, but we're dealing with an individual patient who has healing in their valves, valve in valve, or a single implant, which is a little bit different, and they're a little bit more procoagulant. So I think there's this individual tendency towards this as well, which we unfortunately will never be able to figure out into trials, but we have to use, as as John says, a clinical judgment in this group of patients and say, look, I think these people are at higher risk. And
yeah, would you comment maybe on what the potential factors are? Are we learning in which cases we do see more leaflet thickening, in which cases we see less? The question of smaller valves, like valve-in-valve situations, or oval-shaped or supraannular. Would anybody comment on that?
So I think the early indication for sure that John has mentioned earlier is valve-in-valve, especially small ones. Smaller anatomies in general, I think, are more prone for this phenomena. From earlier analysis, what has been published, it's pretty unclear about is there a difference between different TAVR valves or surgical valves, but there seems to be incidence across all the devices. What is more important, I think, is to understand, are there any patient-related factors as well? Patients in AF, for example, are already on anticoagulation, so we don't analyze this effect. Right. But those who are not, I think, and what INR levels we have to run at, these are going to be important things.
Any additional comments, Chris?
No, I mean, I don't know, John, if you've got an experience, have you seen patients with follow-up CT who are already on anticoagulants? Is there a difference what their valves look like?
I don't have much to contribute to that. I guess it's pretty clear, though, that if you're on anticoagulants, you're less likely to have thrombus. And if you have thrombus and start anticoagulants, it's more likely than not it's going to improve.
Yeah.
And so there's clearly a relationship.
The antiplatelet therapy that we have established, beginning with TAVR, wasn't really based on anything. No, it was just purely empiric. Do you think that in the foreseeable future, our regimen will change, or maybe even away from antiplatelet, more into anticoagulation?
I think definitely. You have already answered the question. I think one of the early knee-jerk reaction when this issue was brought to highlight was, oh my God, everybody is going to start anticoagulation and a lot of patients are going to die with hemorrhage. That's not happening because majority of the patients we are treating, the median or average is around STS score of 4 now. So these are relatively healthy, conscious patients which we can monitor easily. I think starting anticoagulation for 3 months is not a bad idea. And if you can't start anticoagulation, then monitor them early to make sure that if there is an increased gradient, then we start them selectively. I think that's the approach we have to take.
Chris?
Yeah, I think it's going to be hard. Personally, I think it's going to be hard to prove, yeah, you have to use this for this length of time. And as Vinny said, it's going to be clinical judgment. I think this is a good idea. It's low risk to the patient, and that's probably how practice will move forward, I suspect.
So, like you, I was one of the people that can be blamed for starting Plavix years ago, and I think it's time for us to think about abandoning that antiplatelet, single antiplatelet alone. But I really do think that it's very likely that some other regimen is going to become fairly routine, particularly in high-risk groups. I don't know which one.
So we have 1 minute left, and I have a personal question to each of you. I know you don't have TAVR, and hopefully you won't need TAVR, and I don't ask which valve you would like to have, but what I would like to ask you, and maybe John, you can start. If you happen to have TAVR in the future, would you like TAVR?
Can I do it myself?
You can come to Colombia.
Protection, with or without protection? And would you like to have NOACs, suppose you don't have a high bleeding risk? Could any of you answer that question? We have 1 minute left.
Well, I have a low bleeding risk, so I'd be happy to take NOACs, but I wouldn't recommend it, and I'd just assume people didn't know about it, but I would probably do that. Sentinel, I'm truly not a believer, but if it was somebody really good, I'd let them put a Sentinel device in me.
Good. Chris?
I would have to say the same thing, really.
Well, I'll definitely have Sentinel, and I'll have it under general anesthesia with T guidance. Definitely shows that there is no PV leak or how much it is, and I think and I will definitely take anticoagulation for 3 months.
That's quite interesting, isn't it?
Great. So
You didn't answer your choice.
no, I would say the same thing. I would take. Suppose I have a low bleeding risk. So far, I do.
Minimally
I would
invasive
take
TAVR,
NOACs, and I would like to have protection. So thank you very much. I think we're finishing on time. Thank you very much for your contribution.
Thank you.
I wish you a great meeting here and a safe trip back. Thanks for having me here.
Thank you.
Thank you.
Bye-bye.
Good.